Dr. Amit Thapa from Kathmandu to talk on degenerative spine diseases.
Thank you, Chairpersons. Good afternoon, everyone. A warm greetings from Nepali Society of Neurosurgeons. Well, I'm bringing a topic which I have realized is unique for this whole conference because this is the only one topic on pain injections and how to use it in a pre-operative phase. Well, I have nothing important to disclose except for the fact that the consent has been taken and few companies which I may be taking it just for the academic reason. And I truly accept that all my previous speakers have done commendable work and most of them are supplementary to my topic even. So we know that the low back pain is now a growing menace with almost a lifetime prevalence of 54 to 80%. And being a second most common reason for anybody to visit an OPD, this is clearly getting its sheer size of financial impact also. And in Nepal also over the period of 30 years, it has been the #1 cause of the year's life wasted due to disability, and it is growing in proportion. So the data in 1990 was 6.2 proportion. It has gone up to 7.4 proportion in 2019, despite of all the advancements. And the most important thing is it is affecting the middle-aged adults. And that's the reason why this particular pain procedures has come up into vogue in the market, and a lot of pain physicians are doing this procedure. They are trying to elevate the pain. The main key point which I want to focus here is how to use this procedure for diagnosis the pain thing, because we as a surgeons are much more involved in surgical care, be it a UB decompression or UB fusion. So we do a lot of good things in the patient's care, and this has also picked up in Nepal in a very big manner. But what we are missing is identifying the pain generator. This is a visual match between Mike Tyson and Franco. Both are look at that one shot. And that one shot has actually made the opponent fall down to the ground. And this is what the surgeons are looking at, the pain generator. Where is it? And if you read this article by Dr. Ed Benzel, and he had rightly used this word, pseudo-concordance. Sometimes we do a clinical examination and do an MRI, and we're so confident, okay, we had picked up the spot. And somehow it is just like trying to find the part of the elephant in a dark room, and that's how the pseudo-concordance can actually mislead you. And that's why this concept of pain generation, as we should all understand, is a pathoanatomic concept, and these are not always visible to one on just clinical or even on radiological evaluation. And we know this, that the non-innervated structures, the ligamentum flavum, internal annulus, or nucleus pulposus, by their virtue of its anatomical non-innervation, they should not give any pain. But as the degeneration process occurs, because of this injury, spasm, and all this healing cycle which occurs, these non-innervated structures start becoming a pain generator, and that's why these pain generators have to be identified by meticulous uses of this pain injection so that we can hit upon what type of procedure would be better. Say, for example, if a patient is having a facet joint pathology together with a disc problem, then we should always go for a facet joint intervention rather than just giving a nerve root decompression surgery to these patients. And similarly, fixation would be far better in these patients who are unstable at the same point. Now, this is a paper which was published in 1998. I would just like to draw your attention to the low back pain analysis of 104 patients. The researchers then had found that almost 39% patients did not have any diagnosis of the pain generator despite of using a good clinical exam, MRI, and CT scanning these patients, and even neurophysiological examinations was done. And in these patients, when they tried a pain injection, they found that almost 24% patients had a facet joint pathology over top of the 20 or the 24 patients who had a combined pathology at the same time. So these studies do show that, of course, we may be misled by our clinical exams as well as of our radiological examination for confirmation. So pain mapping actually helps us not only to identify the pain source, but also can help us to guide what all the surgical planning one can help. And depending upon your intervention, you can predict what outcome the patient is going to get. And of course, it improves your patient selection, reduces the surgical risk, including the failed back spine surgery syndromes. Now, we all know, we all do this. We do good history taking, we do physical exam and imaging. We use this maps to identify the pain, and in this case, the patient's pointing test is very, very localizing thing. Then pain spine examinations, we do provocative exams to find out whether the SIJ joint is also involved in these types of pain problems. And of course, we complement with the imaging. And there are a lot of spine injections these days which can be used for various pathologies, but I'm not going into detail because that's not my perspective of the talk. What I'm going to talk to you about is how we use this pain mapping for our patients. So we use basically a very standardized diagnostic block evaluation sheet And the principle is to have a patient for this testing only if the patient's visual analog scale is more than 5 out of 10. Anything below this, patient will not be able to tell you whether he got a benefit out of the intervention or not. And we always start with a selective nerve block, and not more than 2 levels at one given point of time should be checked. And we always inject the most probable source of pain. And once the procedure is over, we like to check the patients on the table itself, whether the patient has the problem on flexion, extension, side bending, sitting or standing. And then we keep on evaluating these patients times and again, first and 30 minutes later, 2 hours later. And even once the patient goes back home, he goes with a pain diary and comes back again in the OPD to tell us whether the patient had a 50% relief in the pain or not. If the relief has been more than 70%, this is super convincing that, okay, that we have found the pain generator in this patient. So how we do it is a list of these simple tests: selective nerve blocks followed by phased injections if in case it is necessary. If in case we are embarking on a diagnostic medial branch block, so by the virtue of the medial branch, we have to always give infiltration a level above also. And then diagnostic SI block can be tried. Lumbar discogram has actually gone into very much less use these days. I have not been giving lumbar discogram for a very long time. So in the selective nerve block, as we all know, we always use the needle and then always use a contrast to identify our location. And then this is a case of a medial branch block and sacroiliac joint injections. And then the discography. Now, if we come to the effectiveness, of course, the effectiveness depends upon what is the pathology involved in it. If in case this is just a case of a synovial inflammation, patient with a combination of a bupivacaine and a steroid have a very good relief, even to a tune of around 3 to 6 months. However, if the patient problem is because of mechanical or neuropathic nature, then corticosteroids will not give a long-term effect. It will just give you a small effect of a few weeks duration. However, this particular method itself can make your patients able to adapt to the physiotherapeutic maneuvers which will relieve the patient over a long period of time. Now, World Neurosurgery has also come up with one of the recommendations by the spine group of WFNS, and they also have found that the epidural injections have been better. But for the pain mapping, we're using transforaminal, not the interlaminar one, because interlaminar injections actually spreads the drug all over the levels, where the transforaminal, you can be much more localized in your infiltration. So just to share our experience, we have done almost 140 patients in this study, which is still in process. We had actually presented our paper in 2003 in one of our meetings in Nason. And in this paper, what we did was we actually subjected these patients for pain mapping, and we could do away with the surgery in almost 70% patients. We are still following these patients whether they come back for the intervention procedure, and we have found that all those remaining 30% whose the intervention had been performed, patients are still doing good. So we are still following both the categories of patients who are doing only without instrumentations or the definitive surgeries, and who have been managed with the interventions only. So we always like to rule out the red flag signs. If the patient has a red flag sign and definitely there's a concordant signs in the imagings, then we go for the surgery directly. Or those patients who have just not have a red flag signs and have a dubiosity or multi-location of the pain, then we always go for the pain procedure, particularly the pain mapping. And we all know about the red flag signs, so I don't have to repeat it. What I also want to highlight here is that yellow flags are also very important, particularly in cases of chronic pain because of the psychosocial impact of this pain over a very long time. And whenever the patient presents to you with a negative attitude towards the back pain, it is always very, very important to expose these patients to psychological intervention, which has been presented in one of the article in JAMA Psychiatry, where they have exposed these instrumented patients for the pain reprocessing therapy. It's basically a set of psychological interventions which is provided to the patients in the pre-operative phase, and involves almost 4 or 5 settings over a period of 4 to 5 weeks of psychiatric counseling, where the patients have been actually been tuned to remove that particular negative attitude to their pain. And this has been shown to have excellent results, almost 3 times more beneficial impact with the surgery after this particular impacts. However, pain injections have to be done only after proper training. So nowadays, there are a lot of intervention courses which are going on. So this can be done. This is not as easy as it is shown in one of these websites, where the patient is just asked to point on a body where the patient's pain is, and subsequently you can be given a list of intervention which has been done. But surprisingly, The websites are full of these types of articles also, where they are claiming that the personalized pain mapping can be provided to the patients. And of course, as a surgeon, we should be aware of this particular modality to actually enhance our procedure. So pain procedure, they're both diagnostic and therapeutic. My dear friends, we always want to do a diagnostic tab, particularly from our side, so that we do not mix on the patients, and the pain generator can be identified together with the triad of a good history taking, clinical examination, radiological investigations. And if in case we don't have to do this pain procedure for all the patients, but if in case you have a doubt, it's always better to use these pain mapping techniques to identify your pain generator and then decide on the surgical interventions. And beside the red flag signs, the yellow flag signs should also be considered to have a very good results. And of course, we should remember that the pain management is a multidisciplinary approach, so do not be shying away by not using your other colleagues into the wholesome treatment to the patients. Thank you for your patience listening and open to questions. And I invite all of you for the 11th National Congress in the beautiful city of Itari and Biratnagar. For those of you who are not aware of it, it is near to the city of Ilam. The tea gardens they are there. They are beautiful to stay. And it's a month of November 14 to 16, always a pleasant time to come to Nepal that time. Thank you.
I have the question.